Hello, everyone. We will wait for a few minutes for everybody to join in. Thank you so much for everybody who has already joined in. Another 3, 4 minutes before we join in. We'll wait for everybody else to join in, please. Since we have, more people joining us, so we will wait for another 3, 4 minutes. Thank you so much, everyone, for your patience. we'll get started now. Hello, everyone. A very, very warm welcome to all our participants joining us today from different locations. I'm very glad that we have senior doctors and healthcare professionals from various insurance companies and TPAs across the world joining us today. On behalf of Prospera, I warmly welcome you all for today's webinar on proton therapy. Thank you all for your time. We truly appreciate your presence and interest in advancing knowledge in oncology care. At Prospera Global, we continue
physics picture. I don't want you to give more power to this because it has evolved over time. Initially, it was called passive scattering. A proton beam would come, you would diverge them to whatever depth you want, and you would block wherever you don't want. Now we don't do that. We use a very thin or a pencil beam of proton therapy. So physics picture two ways of knowledge because it has evolved over time. Out of energy, what is available in the proton, you split time based on the highest energy to the lowest energy. So what this does is it creates radiation doses in various layers, in various spots. So what we eventually do is to treat the tumor not as a whole, unlike in the older system, but spot by spot, line by line, and layer by layer. So Apollo Proton Cancer Centre in Chennai, the concept of procuring a proton therapy center started way back in 2012, if you look at it. And then over time, multiple other procedures, multiple licensing procedures happen, and the equipment comes to the city. Usually it comes by port because they are huge equipment parts, and then they are assembled. It takes about a year or two for the assembly to happen. And then eventually, when the first patient started, it was somewhere in Jan 2009. So the first child was a boy from Jodhpur. He had a benign brain tumor called craniopharyngioma, and he is now a big boy. We also saw him recently, who came for follow-up, and he is doing extremely well. And over the last 6 years, we have treated close to 2,500 or more patients. Typically, 24% of these patients are children. When I say children, they are as young as 1.5 years old, and we have even treated patients of various other histologies like prostate or gynecology or gastrointestinal or bone and soft tissue, and the oldest patient we have treated is somewhere around 89 years old. So if you I'm just trying to see. So if you classify, sorry, I'm just taking a moment. I'm sorry.
So you do वाले पे एक लाइक कर देना.
YouTube पे है. Live.
ये लाइव है.
Yeah. So if you classify. You would like to use in various medical situations. You can divide them I would classify them into 4 situations. One is where the target volume is in close proximity to any critical structure, and because of which we have to significantly underdose therapeutic dose. So if you take examples of those, they are typically called chordomas. Most of you may have come across these cases. Usually they arise from the surface or they arise from the sacrum, and usually very aggressive locally. Whereas if you ask, you may have heard of so what happens is these tumors require very high dose of radiation, and when you have to deliver a high dose of radiation to these tumors at the same point of time, you cannot underdose them because there is a structure called brainstem which is very close to this. You would typically use proton therapy because of the results what I'm going to show you in the subsequent slides. So there is a first indication. Secondly, like I showed you a large slide wherein you have to treat a large bit of the body like the brain and spinal cord. The CSF space in the brain and spinal cord can be toxic to can be having circulating tumor cells. What you have to do is, if you use proton therapy, it is that compared to photons, normal tissue irradiation can be significantly lower. Thirdly, wherein the photon plants can be prohibited. Like you have got a lymphoma in a small child, there is heart, there is lung, there is vegas, and even though the radiation requirement in a lymphoma or in a germ cell tumor of the mediastinum is very low, you may still have some radiation dose going on in the heart or the lung or other structures which can be having a lot of significant impact in a long term, in a long run. Or in a fourth situation wherein you have to use radiation the second time when a tumor recurs, or when there is progression, or there is a malignant transformation, you can use re-irradiation with proton therapy because proton therapy gives less radiation dose. So over the next few slides, I would like to show you few of these clinical indications. I don't expect you to remember anything significantly with respect to biology. What I would like to show you is how important it is to understand what proton therapy does. So, initially, when you see when they take single arm studies, like you have got your own conventional technology of radiation delivery in these children, you start using a new technology and then you compare dosimetrically what is the extra radiation dose what you give. So most of these studies started from initial centers of where proton therapy was available, like in the Mass General Hospital, San Francisco, or in St. Jude's Children's Hospital, or in other few centers in the east. Predominantly, they were all from the west. So, if you see, when they looked at the toxic effects of proton radiotherapy versus the conventional radiation therapy, they found that the excess radiation what the photons would do was significantly higher. So the dose reduction to the structures like cochlea and the dose reduction to the heart, you can see yourself, was in these proportions. So with this preliminary information or with this preliminary study characteristics, many centers across the world started testing the same technology in a larger or in different organs at risk. Like a group from Canada, although they do not have proton therapy with them, they took their own children cohort and they compared with the children who received proton therapy from US, and they compared that when you use proton therapy, the global IQ, the intelligent quotient, the perceptual reasoning, working memory of these children who received proton therapy in US compared to what it was in Canada was significantly different. So we also have tested in our own group of patients. In these cases, it is called neuroblastomas, which arise from the posterior part of the brain, has got 50% of fluid on the CSF. We have found that when you substratify them into different groups of medulloblastoma, also the impact of proton therapy is significantly higher compared to our own historical cohort. So one such study I have tried to put you here. I don't expect you to have more understanding of this paper. What I have just tried to show is what they did was they tried to see if you gave additional dose of radiation with conventional radiation therapy compared to photon therapy, and if you compared each 5-gram increase in the dose deposited, or if you look at the volume increase in the radiation to each part of this brain called the whole brain, or the frontal areas of the brain, or the area called hippocampus which controls our memory, etc. You see the medians of the IQ or the medians of volume of the brain and volume of these receiving is significantly higher with white, which is photons, while it is lesser with protons. So what they could conclude from this is the processing speed index and the working memory index of these children in Canada compared to the children in US was significantly different. So within FACC, we have created one of the largest numbers, especially in these children. Treating these children is quite complex. They need anesthesia. You see more than 4-year-old children, and the statistics of major international journals. So medulloblastomas can also happen. So we also have seen older people with medulloblastomas being treated here, and also who need re-irradiation. So these are some of the situations. In Singapore, I presented the results in the ISBN, which is Philadelphia. So this is a snapshot of what proton therapy can do. My youngest child we have treated is about 1-year-old child. More than 30% of these children require anesthesia. So the lengths of the craniospinal irradiation can vary up to 80 centimeters, so it is quite challenging. You will have to make sure that you are covering your target to as much as possible to make sure that you don't underdose any area. While you are treating these patients, you have to make sure that the shifts or they don't move during treatment, even in older children who don't need anesthesia. And our follow-up and the results have been absolutely impressive. So Germ cell tumors are one another situation which are potentially curable for life. These children have to be properly diagnosed and they have to be managed in a multidisciplinary manner. We have to make sure that the toxicity have to be as low as possible so that we don't give them any complications because of it. So once a child was a boy who was 18 years old who had a germ cell tumor arising from a critical part of the brain called basal ganglia. And these germ cell tumors which arise from the deeper part of the brain, they tend to have CSF spread. So after the chemotherapy, to initially reduce the volume of this tumor, which is not seen grossly on the MRI, but they may be circulating in the CSF space in the brain, we take them up for radiation. So this boy required craniospheric radiation to a dose of 40 gray, and we have significantly, this is one of the initial patients who presented us in APCC, which was treated way back in around 2020 or 2017, I think, 2020 or 2021, I think. So he was on follow-up, and there is significant reduction in the tumor as well as in the tumor marker in most of these children. So germ cell tumors are the most commonest tumors with significantly higher survival. So if you look at germinoma germ cell tumor or non-germinomatous germ cell tumor, both have got significant long-term survival benefits. So when you tailor the treatment well, then you can expect them to have long-term survival with minimal side effects. So this is one such case in a 16-year-old boy who had something called a choriocarcinoma, which comes under non-germinomatous germ cell tumors. So these can be extremely aggressive. They can have beta HCG as much as 1000 or beyond. Like in this child, it was 1626. So initially, like the other child, also after the chemotherapy is over, we had to treat the entire brain and spine space. And many years after follow, the boy is doing very well. The markers have normalized, and so far we have had at least 25 to 26 kids of this very rare situation called germ cell tumors, to treat them effectively without giving much complications. So this is another situation where you have a germ cell tumor which completely regresses with chemotherapy. So you need not treat the brain and spine completely, but you will have to treat something called as a whole ventricular artery. So these germ cells can be floating in and around these ventricles, and you have to essentially mark the ventricles and then give a margin around it and treat called ventricular artery. So when you do that, these ventricles can be overlapping these areas of the brain where it can be having impact on long-term complications. So one such situation wherein we had to use proton therapy for a whole ventricular artery, also you see beautifully there is hardly any dose reduction in brain compared to the red area which needs full dose, and the yellow and the blue line which are low doses. Typically they stop short of the normal tissue toxicity. So I will quickly take you through the most deadliest disease in the skull base called chordomas. So chordomas, from many decades, people have been challenged extensively because it is quite locally invasive disease. The radiation dose needs upwards of 60 gray of radiation, and 60 gray of radiation, people would imagine that it cause significant complications in the brain if you deliver it proper imaging or proper understanding or way. So what we did was we looked at patients who were not optimally treated. So they were called those layer 1 compromise, or they were not being able to treat it properly because the tumor was not completely removed, which is called a type 2 dose compromise. And we saw that the survival was significantly different if you still had a tumor in the brain, or if you had to compromise only because you couldn't use proton therapy. So like I told you, treatment of a chordoma is a multidisciplinary. This is a neurologists and radiation oncologists. So if you see this tumor which is arising, this is the brain, part of the brain. This is the brainstem, and that's part of the brain, the bone in the skull base from which this tumor arises. So if you see, if we had planned proton therapy directly in this patient without doing any surgical intervention, we would have ended up giving only 50 units of radiation, which is not enough for this patient. So what we had to do was go in again through the nose, which you can see in the because of the physical properties of this proton therapy, what happened was that we could significantly improve the dose of radiation from 50 to 65 units, and the chances of control so if we switch from these to more durable very
उसमें तो इन्फिनिटी वाला आएगा इन्फिनिटी वाला जाएगा
ये तो उससे कर रखा है ना
प्रॉस्पेरा से
कम्युनिकेशन से
हाँ, ये तो आ ही रहेगा आपके
है
पास
ना ये कम्युनिकेशन से मेरे कॉन्टैक्ट जो मोबाइल में
Radiation
से गया है ना
हाँ, ये जो
in children less than 3 years of age can be extremely challenging. So surgery itself is very complex, and after surgery, if you don't treat them, the failures can be very high. If you don't deliver a good amount of radiation dose, it is impossible to expect a cure. And so people have tried all sorts of modalities, and people have come to an understanding that until and unless you deliver this dose of 59 gray, it is impossible.
रॉकेट साइंस में था हम पहली बार कर रहे थे हमें ऐसे लग रहा
अब ऐसे लग रहा है ना कि आसान था
हाँ मैं कर दिया
मुझे ये बहुत आसान लग रहा है सर जबकि मैं इसमें 3 दिन हो गया मुझे लास्ट में फिर भी गड़बड़ हो रही है लास्ट में डिसेबल वाली
So what people follow now
हमने वैसे ही करा ना
surgeries to keep the residual disease of in the tube.
लेकिन मेरा कोई यूट्यूब देख भी नहीं रहा है कोई देख भी नहीं रहा है
And then give immediate boost of radiation.
यूट्यूब वाला
If possible, therapy so that you can
यूट्यूब खोल
improve
कर देख ले
the
एक लाइक तो कर दो इतनी मुश्किल से बनाया मैंने यूट्यूब वाला
ठीक है
So
इसका
यूट्यूब में चल रहा है
प्रॉस्पेरा पे सीधा चल रहा है
because these are very very small children, what happens
एक
is
like कर दो।
the brainstem
ऐसे हो जाता है
is
क्या
very close
कौन
to
सा आ रहा है
these tumors can be significant. Brainstem dose can be significantly high.
शक्ल भी दिखा सकते
So when they compared the two modalities of radiation,
यूट्यूब ऑन करो तो आ जाएगा
हाँ प्रॉस्पेरा का सर्च करो आ जाएगा
then you could see that proton therapy could reduce the radiation dose of large structures
वो मुझे खा लेंगे
by a factor of 2.
केमिस्ट्री में
They
देखो
also could reduce the
सबने फोन में
radiation
करा
dose of
केमिस्ट्री
which is important for the vision.
अरे वो प्रॉस्पेरा ग्लोबल सोल्यूशन
At the
हो रहा
same
है
point of time, they could also make sure that the 5-year local control and the overall survival did not dip because we had to choose conventional radiation therapy with chemo versus directly giving proton therapy. So our experience of proton therapy also has been quite extensive. This is an old slide, so we will see
प्रॉस्पेरा ग्लोबल से नहीं आ रहा है क्या
about 70 to 80 kids with this complex
प्रॉस्पेरा ग्लोबल ही है तो वो दिख रहा है
being treated. So you can see that patients come to us with a situation like this. You can see this is a normal brainstem. These are the two nerves of the ear, and there's a tumor left behind. So we have to go in again, and we have to make sure the surgery is completed. We get a clean cavity of without a disease there, and then we do proton therapy
लाइट
to
कर
make
दो
sure
कहना
that we
मुझे
optimize
हाँ
the
बस बोल दो
and
दो लाइट आ लाइट लाइट बन रहा है टीवी किसी
of 3 years.
टीवी तो खोल दो
So again we have to.
चलो आप अपने वाले से कर दो
Why am I showing only these volumes repeatedly? These are very challenging cases. Whether it's a medulloblastoma, whether it's a germ cell tumor, whether it's a recurrent epitheloma, or whether it is a chordoma. These are 4-5 indications. All of you have to keep in your mind. I'll repeat again, which is a medulloblastoma, an ependymoma, a germ cell tumor, and a chordoma. These are 4 indications wherein if you choose proton therapy optimally, and ideally these children can be cured completely, and these children and young adults, typically it happens in children and young adults, they can be cured completely without getting long-term complications. So the last cohort of patients which I would like to show in my talk today is something called a craniopharyngioma. Craniopharyngioma is a benign tumor. So there is a gland called the pituitary gland, which actually when the brain is formed is in a different location. So as a natural process of evolution and development, what happens is the gland travels from one part of the brain through a duct called the pharyngeal duct. And this duct is also responsible for formation of the tongue and other structures in the throat, like the thyroid. So in some children, what happens is this duct, which is supposed to disappear with age, remains and this duct collects fluid and becomes calcified over time.
हाँ क्या भरा
So
आपने
this
जिमिल वाला
can
भरा
cause complications in terms of pressing on the eye nerve, and causes compression of the optic rhizome and causes blindness. It can obstruct the ventricle, and this obstruction can cause enlargement of the head, and this also can cause dysfunction of the brain adjacent to it. They can cause seizures, and these children can also have dysfunction of the hypothalamic axis because because the cyst is sitting right next there. So until many years, what people would try to do is they were trying to chase every single aspect of the cyst radically, do multiple surgeries, try to extract them completely, and try to create a zero environment of cyst there. While doing that, you may be damaging a lot of structures around it, especially the optic apparatus, and the brain of a small child. This typically happens at a median age of 6 years. Can get damaged, and these children can become permanently hypopituitary, so they need replacements for life. So what many centers in the world, including ours, have tried and done is we try to do limited surgery just to decompress the cyst. So you can just have to aspirate the cyst out so that you get a reduction in the dose. The compression which is happening on the optic rhizome can be reduced by cystic decompression, and then you try to give proton therapy to these. Previously, we have done conventional radiation therapy. Our randomized control trial, what I showed you in the first slide, was on testing these tumors, these patients with conventional radiation therapy. Because we have demonstrated significantly higher outcomes by using a smaller volume of radiation, we tend to use many centers in the world tend to use proton therapy in these children, because you can further reduce the volume of radiation to these structures called the hippocampus and the temporal lobes, and you can still give them a long-term survival. If you manage these patients properly, the local control and the survival, like how we have shown in our own patients, is 100%. Every child can be treated very well. So I've just put up a case example here. You can see a first child, how the tumor was a very solid tumor, a calcified mass sitting there. It had to be operated and we gave proton therapy, and look at the result over time. So this was the situation when they came to us before radiation proton therapy planning, and the way it was responded is very good. So if carefully chosen, these patients, it was 30 before, now it's about 60-70 children. We have had about 100% disease control, and no child has died because of the disease. There was one death because of a electrolyte imbalance. Otherwise, we haven't had any deaths. So my last two slides, or maybe the last slide, is about cost effectiveness. The question what comes in, or what raises eyebrows of people, is the cost. So why is the cost? Is because I have skipped a few slides which I had in the other presentation. Is the extraction of proton therapy, is the propagation, is the transmission of proton therapy, and delivery of the proton therapy is a very complex electrical and magnetic and other physics procedures involved, which makes it actually complex. One. Secondly, the CT scans which have to be done every day to verify and make sure we are treating the same area every day is quite complex. Third, these children need MRI scans repeatedly. They have to have thorough evaluation almost every fourth fraction, every fifth fraction, which makes it quite complex. So, and you can't treat many children like how we do, or many patients how we do in a conventional machine. In a conventional machine, if you can treat about 90-100 patients, you can hardly treat about 30. Right now, we are treating about 35 patients because it's an experience center. We know how to streamline the patients, which patients will go in first, which patients come later. So this streamlining is very important to make sure that we use the machine in a most efficient manner. So what people have tried to do is they have tried to compare the effect of conventional radiation, the side effects over time. So this table in the right lower bottom corner, if you see, they have compared conventional radiation therapy and the complications which happen because of conventional radiation therapy over time, like the hearing loss, the hypothyroidism, the osteoporosis, the growth hormone deficiency, and there can be second malignancies because of radiation therapy, because it traverses through the body, like I told you, and there can be fatal events. So if you add all these factors over time, especially in a cost-effective model, looked at a disease like a medulloblastoma, what they have seen, and when they have compared cost alone, they have compared the adjusted life years, quality here, which is a measure of quality of life. The quality alone with proton therapy with conventional radiation therapy was 13.91 years, while with proton was 17.36. And the cost incurred in managing these complications over time when a small child becomes an adult is about $112,000 versus $80,000 of the cost of proton therapy. But proton therapy in Apollo Proton Center, Shaibuddin is there with me, he also will enlighten you, is 1/3 the cost of the proton therapy what it is in US. So we treat children from $25,000 to $45,000 based on various other factors, number of radiation fractions required, how young the child is, whether the child needs anesthesia, whether the child needs chemotherapy. Based on those factors, the cost is calculated, but then it is significantly less compared to the costs in US. So modern proton therapy, especially proton therapy, has both lower cost, total cost, and better effect compared to conventional radiation therapy. Lastly, these are my seniors who have been working here. Dr. Rakesh Jalali is a well-known, worldwide known figure. Dr. Chidikulu Srinivas takes care of children with solid tumors apart from brain. So we have looked at why proton beam therapy is required in low middle income countries. 80% of these children are diagnosed in low middle income countries. So it is better to have conventional radiation. It's better to have proton therapy compared to conventional radiation for the improvement of our gain in the quality adjusted life years. What is the magnitude of need? About 3 lakh patients require radiation every year. We just have 545 10 therapy machines. So we need to have more patients who will benefit with proton beam therapy. So what do we have to do to fill this gap? We need a tier-based system among the regions. So we cater to Africa, we cater to Middle East, we cater to Central Asia, we cater to Burma, Bangladesh, Nepal, the island nations in the Indian Ocean. So we need to have a tier-based system. So we concur with the local radiation oncologists, local oncologists, try to explain what proton therapy may impact on these children, and we try to understand what the child needs. We have repeated calls, whether it is telephone consultation or phone consultation or video consultation. We talk to their radiologists. We share our plans. We show our protocols, and then we try to make sure that every child who deserves proton therapy through any of these regions come here for proton therapy. So proton beam technology is an engineering model. It's of great benefit for a few. It's of incremental benefit for some. And however, having said that, it of course may not be benefit for many, but when chosen very well, it can be definitely cost effective and improve the quality adjusted life years. With that, I thank you for your kind attention, and I'll be open for any questions.
Great. Thank you so much, Dr. Uday. Thank you so much, Dr. Uday, for that insightful and detailed, informative presentation. We truly appreciate your taking the time to share the expertise and valuable perspectives with us today. Alright, we will now begin the question answer session. I request all participants to please share their question in the chat box if you haven't already. We will take up as many questions as time permits over the next few minutes. We have already crossed 1 hour of time frame, so let me just see, we have a couple of questions here. Okay, so Dr. Uday, with your permission, let me just quickly ask one of the
I am trying to type the answers here itself, while I can do multitasking. Keep typing here the answers as well as answers to any questions online here as well.
Okay, great. So the first question is, what are the indications of proton therapy other than brain tumor? Is it mostly for children?
Yeah, so adults basically you will have to look at what normal structure are we looking at sparing over time. Just give me a second, please. I'm sorry, I think it's an emergency call. Madam, 5 minutes, I'll call you back, okay? 5-10 minutes. I'll call you back in 10 minutes, madam. Sorry about that. So, we have to look at what critical structure are we sparing. For example, I've put left breast cancer here. So, left breast cancer, we can reduce the radiation dose by about 90% with proton therapy. Prostate cancer, for example, you can reduce the rectal toxicity and urinary tract toxicity. You are talking about mediastinal lymphomas. So these are patients who can be completely cured. So these are situations wherein you expect that the radiation can affect even a well-developed tissue, can have problems in them over time. So I think these are the absolute indications what I have put. Is indication backed or experimental. For all children, it is proven, and for adults, there is something called as dosimetry comparison, which means if you can prove that dosimetrically it is superior, then in adults we definitely use this. Survival advantage in the situations like chordomas, what I showed you, in situations like medulloblastoma, what I showed you, and in ependymoma, what I showed you. So these situations wherein it is, yeah. So the FDA approval for many indications came in as early as 2006.
Okay, there's one question from Dr. Waqas Ahmed. Dr. Day says, how does proton therapy impact healthy surrounding tissues compared to traditional radiations?
Yeah, so for example, you have got, so I was showing you the first slide, which is called the integral dose, which is dose deposited per kg. So if you have to expose a small child who weighs about 10 kilos versus you have to expose an adult who weighs around 70 kilos. The dose of radiation which goes into the body is same, but the mass is less in a small child. So what happens is you can reduce the exposure areas by using various new technologies of radiation. But then the impact or the intensity of this radiation to each tissue, you will not be able to control with conventional radiation therapy. And that is when proton, like I showed you in the first slide, has been biologically compared with conventional radiation at various sites. I had to restrict my number of slides because of the time, but otherwise I could have showed you at each biological tissue what we could change and what we could do. Yeah, so lifestyle changes and rehabilitation is required. Yes, required. Like I showed you, wherever we need it, wherever you need repeat surgery, you have to have repeat surgery. And then wherever you need to have modifications in the organs around it, like for example, rectal filling, emptying, urinary bladder filling, emptying, or if you have got something like a patient for whom you have to treat a stomach cancer or a pancreatic cancer, there are some recommendations or lifestyle changes that have to be used to make sure that proton therapy is more effective compared to others.
One interesting question, although you have answered, just for the other attendees who are not reading the chat, Mr. SM had asked, is proton therapy FDA approved? And you said yes.
Yes.
It came in early 2006. Yeah.
So this is not long-term hospitalization cost or recurrence of malignancy after proton therapy. So what I have to emphasize is proton does not change the biology of the tumor. If a tumor has been malignant from the beginning, it will remain to be malignant. It does not change the biology of the tumor. But having said that, whether it is in hospital treatment, it is not. It is an outpatient treatment. It is an OPD modality of treatment. So patient does not have to be admitted in the hospital. They just come take treatment and go back home. But if we are treating something like a child with a tracheostomy, right now we have got about 4 children with a tracheostomy with a range tube. In them, of course, we have to admit them in the hospital if suppose there is a requirement. I can see there's a question from one person by name Nada in Arabic.
Nada. Yeah, in Arabic I've just translated it. We will just take it up. I will just translate it for you. It says, is the cost proportionate to clinical benefit, as many times the cost reaches aggregate insurance cover limit and deprives member of availing complete treatment.
Yeah, so the cost is directly related to the number of fractions we need. So for example, in a child with the optic nerve tumor, like a tumor is coming from the nerve which reflects the eye, they just need only 25 sessions of radiation or 20 sessions of radiation. In them, the cost is significantly less compared to a child who needs 35 sessions of radiation. So the cost part of it, I will request Mr. Shahid to share different things how we do for different situations and indications. Very rarely we treat children with 5 fractions of radiation, especially those with tumors which are coming from the vascular blood supply. In them, just 5 sessions of radiation is required, and then the cost is significantly low. So the cost depends on how many days do we have to generate proton therapy for this particular patient, and how long the treatment is going to be for each patient.
Okay, okay. Thank you, Dr. Uday. And another one very quickly. There is one person, Mr. Abasi from Uganda, East Africa. He says, how many sessions should a client receiving proton is expected to have? Although you have answered it, Dr. Uday, I just want you to.
Yeah, so it will be anywhere between. So usually we do not recommend patients who need proton therapy for a malignant tumor to come all the way. So if we call them, it means they have one of these indications what I showed you, or exceptionally they have low grade. So they need 25 to 35 sessions. So this will be 5 sessions in a week. So it will be around 6 to 7 weeks of stay in Chennai from in to out. When they come here, we start the planning, we execute and send them back in 6 to 7 weeks. So they'll have to stay here for about 7 to 8 weeks in Chennai.
Okay, okay. Thank you. And I think we missed a couple of questions in the beginning. Very quickly, Ms. Pranavi asked, can proton therapy combined with chemotherapy or immunotherapy? Can there be a combination of
so that's when you ask me whether it's only for children or for adults, so that's the new tool in the city which is called ITPT combination, which is immunotherapy and particle therapy combination or proton therapy combination. So what that does is you use immunotherapy to provoke those cells which are quite indolent or quite slow and make them more active with immunotherapy, and then proton therapy will be able to target only them selectively and not treat the other normal tissue. So especially in a situation like a sarcoma or a situation like lung, people have tried to reduce the radiation doses from 5 to 6 weeks to only 4 to 5 days or only 5 sessions, give very high dose of radiation, as much as 15 to 20 doses of radiation every day, and immunotherapy admixed with them, so that you give proton therapy of 20 gray this week and then you give immunotherapy and then you bring proton therapy so that you maximize the benefit. Of course, chemotherapy has been used with conventional radiation therapy, so more the reason it can be used with proton as well. But the immunotherapy to proton therapy is the latest in situation for lung and other things. What is the follow-up care monitoring?
Yeah.
So generally the side effects are very minimal. The side effects are very minimal and they recover also very quickly. But still, the care is almost same as conventional radiation therapy. Occasionally, the mucositis, like for example, if I'm treating a small child with a bone tumor coming from this jawbone, and if it requires a very high dose of radiation, there can be some reactions happening in the oral cavity. They may require parenteral nutrition, other things, but then the recovery rate is quite fast.
All right. Thank you, Dr. Uday. I think we had one more question from Dr. Vikas, where he has asked for lifestyle changes, but I think you have mentioned any specific lifestyle change, any very prominent lifestyle change, Dr. Uday, after the.
So, like I told you, what happens is when you have to treat a critical area of the brain, wherein you have to go in again and operate and put some tissue there, create a gap and things. There are some changes which we expect the patient to understand, like there's going to be an additional fat in the area. If suppose I'm treating a sarcomatous tissue with a very high dose of radiation, we'll have to go in and do some procedures for it, like a plastic surgery and things. Those things are essential requirement. Otherwise, the lifestyle changes are going to be temporary only during the treatment course of protons, and then they can get back to their normal life after that.
Okay, all right. Thank you, Dr.
Okay.
Uday. I think that will be all. Yeah. So I'll just quickly thank you, Dr. Uday, once again.
Thank you so much
for your deep insights. Well, today's discussion has given us a deeper understanding of the proton therapy and evolving landscape of cancer treatment. On behalf of Prospera Global, I would like to extend our sincere thanks to Apollo Proton 3, and a special thank you for each one of us, joining us and taking our time today. Especially people from Oman, UAE, we had seen Bahrain, Lebanon, Jordan, even Sri Lanka also. So thank you so much, everybody. I will just share one feedback link, Dr. Uday, very quickly for our viewers, so that they can quickly do the feedback. And also, let me just share my screen. So everybody can also write to us at contact@Prospera Global Solutions, and also we'll share a specific team link, the feedback link where you can put in your insights, which will be valuable for us for the couple of upcoming webinars. I think we had One more question which was left from Seva, if Dr. They can quickly take it. It was a root cause. I can just check in the chat if you have time. Let me just quickly open the chat.
Yeah, so I showed few of the tumors, but so how do they form? It is basically something to do with pathology and molecular genetics and stuff. So do they mean to ask what is the root cause of these tumors, or what is it?
Let me just see if there's in a chat.
I will ask Mr. Shahid to make this message happen.
Yeah, we are clearly the feedback, and we also going to give you the email. You can send us inquiries and we'll coordinate with you over there. Thank you so much. And also, a feedback link has been shared in the chat box, so right there. And your feedback is extremely important to us. Thank you so much for joining us today. And Ramadan Kareem to all who are fasting and to everybody else, wishing you peace, health, and blessings. Thank you so much, everybody.
Happy festival, all of you.
Thank you. Thank you so much.
Thank you so much. Dr. Uday, I have shared my mail ID. In case any questions are there, they can post it onto my mail ID.
Yes, they can post you and you can answer.
Thank you so much.
Thank you, Shahid. Bye-bye.
Thank you.
Thank you.
Thank you, everybody.
Thank you, everyone. Thanks, Prosperity.
स्ट्रीम कर दूँ स्टॉप कर दूँ स्टॉप स्ट्रीमिंग यहाँ भी चल देगा चल ये तो होगा ना बहुत पीछे चल कर दूँ ना You will be no longer be live. तो बहुत टाइम लगेगा इसको ऐसे छोड़ दो हो गया ना ये कर दूँ ये तो हो ही गया रिकॉर्ड तो कर दूँ भाई
कितना चलिए ऐसा बन गया ये थैंक यू